fallacies of OCT. So a tool that all of us are using, but any tool has going to have a role and it's going to have some fallacies. So over to you, Manish.
Thank you, Arijit. It's really an honor to share this platform with such dignitaries and especially Ramanjit madam. So I'll be speaking on role of OCT and what are the fallacies we have. So why OCT is so important for glaucoma practice? Because, when we were postgraduates, a very common question we had in examination that what is the best pre-perimetric tool for glaucoma, whether it's the OCT or the HRT or the GDX. And this was a very common question. But if we see over time, in 2 decades, the OCT has evolved itself as the best pre-perimetric tool because it has changed, and for our retina colleagues, it's almost indispensable. But over time, the GDX and the HRT have phased out. Now, there are some very important role of OCT in a regular glaucoma practice. For example, a pre-perimetric glaucoma in a patient like this, where you can see there is a clear-cut inferior RNFL defect, you can see here, but the fields are normal. Clinically, you have suspicion of glaucoma, the fields are normal. When you do OCT, and if you see there is a RNFL thinning inferiorly, which is corroborating with your disc finding, it gives you an extra evidence to treat the patient. Not only in this case, OCT helps you to diagnose glaucoma, but over time, if you see this 76 becomes 60 or 50, you can see over the time that the patient is progressing also. So OCT helps you in diagnosis in this case. Also, OCT helps you to assess the progression. But very important that any red or yellow area in OCT is not important. It has to be corroborate with your clinical finding. For example, in this patient, suppose if I do OCT and OCT is showing a superior thinning, not an inferior thinning, then definitely it is not matching and we can't just go by the OCT. Another very important thing is excluding glaucoma. We all have patients who have been suspected as glaucoma elsewhere, sometime already treated as glaucoma. The patient comes to you, you can see there is a superior rim slope. I hope it's visible there. But the RNFL is okay, not looking like glaucoma. The fields are normal. Patient is already on treatment. You want to stop medicine. You do OCT, everything is green. It gives you an extra confidence to stop the medicine and to follow up the patient. So OCT, apart from pre-perimetric glaucoma, has also a very important role in excluding glaucoma. Coming to interpretations, there are multiple machines of OCT. Every machine uses different algorithm for seeing the RNFL thickness. So data from one machine cannot be directly corroborated with the other machine. And so whatever machine you are having, you have to read about the machine, see the printout, try to understand the printout so that you can better assess the RNFL thickness. Like in this case, suppose, but there are some basic parameters which apply to all the machine. One of them is the signal strength. Poor signal strength means the quality of scan is poor, so the picture is hazy. If the picture is hazy, machine will not be able to understand where is the RNFL, where is the IPL, where is the GCC. So it will make false assumptions. Okay, this is the RNFL. So it may give you a false RNFL thickness. So if there is a poor signal strength, you should not use those printout for assessing glaucoma. Apart from that, motion artifacts, you see whether there are any black areas there, any vacant area. Look for centration, look for segmentation. Then you go to the clock hours and then finally the TSNIT graph. So straight away, we have a tendency to first look at those red and green areas. Before that, we should look at these 4 important points. So different machines have different signal strength. For example, the Cirrus is more than 6, the Spectralis is more than 15. So you should know in your machine what is the acceptable criteria. I share a few cases. This is a patient, you can see the RNFL thickness superior, inferior in right eye and left eye. There is gross thinning. But if you see the disc looks to be pretty okay. It's more of a temporal slope in right eye and temporal slope is in left eye, not clearly matching with your disc finding. If we go back to the report, you see the scan quality is 4 and 1, which is much less than the acceptable limit for the Zeiss machine. The same patient, when which were repeated, you can see the scan quality is better and the reports are almost normal. So signal strength is a very, very important criteria. If you're seeing macula, even in a dense cataract or a corneal opacity, you can understand the macular pathology. But if you want to see the RNFL, if you have a dense cataract, corneal opacity, vitritis, severe dry eye, or vitreous hemorrhage, personally, I believe you should not use OCT RNFL for diagnosing glaucoma in these type of cases where you can have a poor signal strength. I'll share another case. This is a patient. Previously, I used to go to Jamshedpur as a visiting consultant. So they had purchased a new machine. Now, this was a 50 lakh machine, a new Zeiss machine. So when you purchase such a costly machine, it gives you a sense of confidence. Now I can diagnose glaucoma. So this machine, this was a patient who was a glaucoma suspect. When we saw the patient looked to be more like a borderline case. But if we see the scan quality, it's good. But where is the disc? The disc margin is all fuzzy. Then there are these black areas you can see here. These black areas are missing data. Next, if you see the TSNIT graph, it is touching the baseline. The arrow is not coming here actually. So TSNIT graph is touching the baseline. If you see the RNFL thickness, it is going 40, 21, 0. If there is one take-home message from my presentation is that if you see any OCT RNFL report where the RNFL thickness is 40 or below, you can be 90% sure that there is an artifact. Because even in total optic atrophy, there is some soft tissue is always left. So RNFL thickness can never go below 50. It is impossible to go below 40. This is what we call as the floor effect. So if you're seeing a report like this, definitely there is some problem with the report. We repeated the OCT in this patient. Now you can see the disc can be seen very clearly here. And you can see the RNFL thickness is much better. Same patient, just half an hour gap, same machine. So the problem was, although the scan quality was correct, but the patient was constantly moving his eyes, and because of which you can see, now the arrow is not coming there. Anyways, okay. It's okay, sir. So because of which you can see this margin was all fuzzy, and that is why it was giving a fallacious report. What is segmentation? This is actually the capacity of the machine to understand where is which layer. That is why, if suppose I have a patient where there is a RNFL thinning, plus there is a macular edema or a disc edema, or there is a epiretinal membrane. So there is an increased thickness of retina. So increased thickness of retina means your RNFL will also become thick. So whenever you have associated pathology like these, definitely your machine will give a fallacious result. Don't use OCT RNFL for glaucoma diagnosis. Coming to red disease is basically the report is all red. That means there is thinning, but the patient is normal. So like in a patient with peripephral atrophy and high myopia, there is a chorioretinal scar around the disc. What is the meaning of scar? There is a thinning of choroid and retina. So if there is thinning of choroid retina, the RNFL is also thinned out. So machine will always tell you that the patient is having glaucoma, whether the patient has glaucoma or not. This is a patient, himself an ophthalmologist, came to us for opinion, having physiological cupping. You can see classical large disc in a large cup. We did a OCT in a spectralis. Now, this is more than a crore machine. So it gives you even more confidence. That can't be wrong. But we see the report, definitely there is showing thinning inferiorly in right eye and inferiorly in left eye. So it confuses you. Clinically showing physiological cupping, why the machine is showing. But if you see the report again, there is a problem with centration. So machine like Cirrus, Spectralis, they always came that there is an auto centration. But when we repeated the test with proper centration, we found the report to be normal. So again, the same thing, you have to trust your clinical finding and always correlate with the, I'll just share few more cases. Green disease, we all know, report is all green, but the patient is having glaucoma. So sometime even in a case like this, where you have early RNFL thinning, the report can be green because machine always gives you the average RNFL thickness. So although there is a thinning, it is still within the normative database. This is another patient, a glaucoma suspect. We did on a spectralis. The report was okay. Same day, we were also trying a Topcon machine. The Topcon machine was showing thinning. Now, Topcon, if you see, have much smaller clock hours compared to a spectralis. But when we compared the two, although the clock hours in spectralis was showing normal, but the TSNIT graph, which give you the RNF thickness at each area, was actually matching with the clock hours. So whenever you're seeing the clock hour, also you should see the TSNIT graph. And if at any point it is going to the red area, you should try to corroborate with your disc finding. Last two cases, this is a patient, very advanced field loss, early young patient. See the OCT. OCT is also showing thinning. But again, the clinical finding, right eye, 0.9 cupping, superior thinning, lot of pallor. Other eye also you can see 0.7, 0.6 with pallor. So whenever you have so much of pallor, you have to think beyond glaucoma. This was a case of methyl alcohol poisoning and patient gave a history of methyl alcohol. The reason I'm sharing this case, OCT will tell you RNFL thinning. whether the thinning is because of high myopia or a trauma or a ischemia-optic neuropathy or methyl alcohol poisoning or glaucoma. OCT will not be able to tell you that. That has to be a clinical assessment. Last patient, this was a patient already on treatment for glaucoma when he came to us. Just a 5-year-old kid. You can see the disc perfectly normal. OCT was showing thinning and the patient was treated for glaucoma. Why? In a 5-year-old, OCT doesn't have the database. So it was showing a fallacious result. Under 18, most OCT machine doesn't have the database. So we kept the patient a follow-up, stopped the medication, and the patient was so smart, even at 7-year age, he could do such a nice feed. So we should not use OCT for patient less than 18 years of age. To conclude, I'll say we all see artifacts in OCT. Whenever you see a patient, look for centration, segmentation, scan quality, look into TSNIT graph, then go to the clock hour. But most important, please correlate clinically, because whether the patient is having glaucoma or not is not for the OCT to decide. It is for us to decide. Thank you so much.
Thank you. Thank you so much, Dr. Maneesh Singh, for this excellent talk, lucid examples, and some mind-boggling numbers as to the cost of the OCT machines. But that's the reality of it. I think all of us are using OCT for, let's say, the initial diagnosis or even for follow-ups. So a quick question to anybody in the panel regarding the use of OCT in diagnosing and initiating treatment.
Hello. I would like to ask the question to Dr. Manish. So can we use OCT in myopic patient as a screening tool for glaucoma? Like ma'am said, we can do a baseline OCT to see glaucoma.
So I think baseline we can use, may not be for screening. Screening can give you fallacious result. But if you want to use as a baseline, we can use it. And then maybe 6 monthly, we can repeat to see whether the patient is showing any significant progression. But we have to see myopic patient in totality. What is the pressure? What are the disc finding and angle? Then only it will be easy to understand whether the patient is actually having progression or not.
So OCT with
Yeah, so just to add to that, because one of my juniors did a thesis on this, so we wrote to these companies and they said that between ±3, you may rely. Above that, don't rely on OCT on doing anything because the correction factor is absent. So that correction factor is still not been incorporated. So be very cautious when you're dealing with myopes or high hypermetropes.
I think Maneesh highlighted very well the role of clinical evaluation, because OCT, as we know, is useful to detect early glaucoma, whereas perimetry is useful to detect the advanced stages of glaucoma. So in most of the cases, the OCT will be useful to corroborate your clinical disc evaluation. So it's very important that we draw the disc, find out which rim is the superior rim or the inferior rim is abnormal, which area you are having an RNFL defect, superior or inferior, and then you should correlate with the OCT. So you are finding that your inferior rim is, there's an inferior RNFL defect, and there's a corresponding defect in the OCT, then, but still the perimetry is not showing a superior defect, then because your clinical evaluation is correlating, then you can think about starting the treatment. Otherwise, it's better to wait.
Yeah, so thank you so much. We'll move on to the next talk, a very, very important talk on ocular blood flow by Kirti Singh ma'am. Ma'am is the director of the Guru Nanak Eye Care Center, and she is the head of the department at MAMC. She is the editor of the Delhi Journal of Ophthalmology, and she is currently the treasurer of the Delhi Ophthalmic Society. So, ma'am is going to talk on ocular blood flow, something again, a very, very important topic, something which is beyond IOP.